And finally, as we discussed, one of the final practice gaps is actual administration of biomarker-driven therapy. Another study, again, a few years ago now, showed that only a minority of patients received biomarker-driven treatment, even when driver mutation was detected. Now, granted, this is a few years ago, but 45% is really a less of a number than what we would like to see in this particular case. This study also identified a lot of patients received immunotherapy, often prescribed instead of targeted therapy, even when the molecular results were available. And I suspect some of this may be because the genetic testing and driver alteration testing takes quite a few weeks, and generally it is a very uncomfortable time both for the patient as well as for the provider to just wait for the genetic testing results. But I think as we've done this more and more, I think both the providers and patients have felt more comfortable waiting for that, because as you see, and you will see during the rest of the program today, that this is really, really important. Because if we are able to identify a genetic driver and target that genetic driver, we have seen much, much more improved outcomes compared to treating everyone the same way as we did in the 90s. Some of the primary reasons for failing to act on positive predictive biomarker results, this, again, the study from 2022 that I showed you with the practice gaps identified lack of awareness of targeted treatment as one of the causes of actually not administering these treatments to patients. Social determinants of health access and disparities, as well as again cost of therapies and insurance coverage being another concern and barrier to administration of therapy. So again, the access and affordability are very, very key issues in biomarker-driven therapy. We are able to identify the biomarkers that are present, but do we have access to the treatments for our patients? This is a study which was recently published looking at EGFR and ALK TKIs administration for patients with non-small cell lung cancer in state Medicaid programs. And again, here it's showing about 30 out of the 33 to 34 states that the author studied in this paper actually had lower than expected range of patients being treated with EGFR and ALK TKIs. So again, access is a big issue. It should not be a barrier. The state that you live in should not be determining the type of treatment you get for your non-small cell lung cancer. So really, this needs to change. And again, more advocacy is needed in this particular area. Affordability is another important issue. Now, a couple of years ago, our team looked at the pricing for EGFR inhibitors and ALK inhibitors, and how over the last few years, the prices had increased, not just increased, but increased over the consumer price index over those years. And again, making affordability and out-of-pocket expenses an important issue. And I think it's very important for all of us to realize that for patients who cannot afford therapy, regardless of the tumor mutational or tumor PD-L1 status, the tumor response rate is going to be 0% if we are not able to administer these therapies to our patients. And so finally, I think I would like to summarize with some potential solutions. As I mentioned, testing, awareness of testing, improving our assays, improving our coverage for liquid biopsy and other infrastructure capabilities like we saw, implementing this to make sure that we are ordering appropriate testing for our patients, expanding the coverage and advocating for patient support systems, out-of-pocket estimation, global expansion of the coverage for biomarker testing, as well as finally administering treatments based on biomarker testing and advocating for coverage of therapies which improve outcomes for our patients is needed. And that is something both the patients and the providers should be teaming up to do.